Japan, Part 120. More funds began to flow into the welfare sector. However, by the mid-1970s, the government and the business leaders, at first quietly and then increasingly in direct public comments, began expressing new consensus. The essence of the consensus is that the welfare state with high welfare and high state burden as found in England, Sweden, and United States is undesirable. By emphasizing the tax burden, Japanese leaders have achieved a measure of public support, but because opposing welfare lacks popular appeal, the new consensus has not been sloganized and enshrined with a fully developed national, nor has it necessarily carried the day with the Diet, which has voted and established more welfare than bureaucrats and business leaders consider desirable. Yet the basic rationale for the new consensus is understood by all in leadership positions and immuted from in a period of low growth with a heavily strained budget. Funds are not available, occasionally appears in the public media. These leaders prefer to keep funds flowing into the productive sectors of the economy, to encourage the working place and the family to share welfare burdens, and to supplement private welfare with state funds only when it is essential to do so. Minimal state welfare. The Japanese lag in welfare expenditures is not necessarily permanent, but the new consensus has already slowed down the rate of increase, and it is tailoring the welfare program in a certain direction. In part of the long-range strategy of the Japanese leaders after World War II was to concentrate first on industrial growth, next on the wages and consumption, then on welfare expenses. By 1973, only 20% of the public expenditure in Japan went to the social benefits compared to 26% in Great Britain, 28% in the United States, and substantially more in all other Western European nations. As welfare expenditure increased, they were concentrated in health in early 1960s, the pensions in the early 1970s, while other areas were virtually neglected. In the health field, of the percentage of the GNP spent for the medical expenditure grew rapidly for several years after national health care was established, and then remained fairly steady except for the 1973 and 1975, when it grew to keep pace with inflation, while GNP remained steady. Overall, the percentage of the GNP devoted to the health care increased by 2.6% in 1961 to 4.3% in 1975, while the GNP multiplied by 7 times in the period. Health expenditure multiplied by 12 times. Japanese expenses on health care, including the ratio of the doctors, nurses, hospital beds to the population, now compares favorably with the Western European average. In the Japanese system, the patient chooses his private doctor, pays a set fee for service determined by the national plan, with the patient assuming 30% of the cost and the rest provided by the national plan. People over 70 have all medical care provided by national plan. Because fees for visits are low, doctors encourage patients to come frequently, and a Japanese citizen visits the doctor more often than citizens in other countries. Although brief visits are not necessarily desirable and may be motivated largely by monetary concerns, in balance it gives more opportunity for doctors to diagnose problems, to catch illness early. Japanese doctors also make substantial income from drugs. Japanese patients consume more drugs than patients in other countries. The merits of this system are now being debated, and the alternatives are being considered. Government payments for a hospital bed are low, forcing hospitals to cut costs, and the period of hospitalization is much longer in Japan than in the other modern countries of North America and Western Europe. In general, Japan has also raised medical costs very rapidly, and their internship and residency training has at times exploited the trainee without providing the well-developed supervision and didactic education about clinical work provided in the American teaching hospitals.